heard presentations on stockpiling, SNS, pods, and the partnerships to support them. We've talked about special populations. Right now, I would like to switch gears a little bit and talk about medication needs beyond SNS for people with chronic med needs before, during, and after disasters. SNS can't be everything to everybody. Sometimes you need things faster than SNS can supply, and sometimes you need items that are not stockpiled anywhere at all. SNS has a very specific focus. They purchase items based on threat that states and local health departments can't supply due to cost or limited alternative uses, and they stockpile items that are predicted to be scarce nationwide or needed in such supply that health departments can't possibly stockpile enough. But what if you need chronic meds that no one is stockpiling and you can't get them because of a local supply chain disruption? What if what you need is everywhere but in your community? What if the pharmacy and prescribing infrastructure are interrupted and you need to restore medication access to avoid a secondary public health emergency from the exacerbation of chronic health conditions? The CDC annual report, Public Health Preparedness, Strengthening the Nation's Emergency Response State by State, lists the prevalence of chronic disease like asthma, heart disease and stroke, and diabetes for each grantee. But remember this statistic: 1 in 3 Americans take prescription drugs for a long-term illness. Chronic medication access can be disrupted in situations involving evacuation, shelter in place, infrastructure damage, or just with your isolated populations. And worsening chronic conditions will significantly tax public health and medical systems already in crisis. Stockpiling is limited by financial concerns, your stock can't be easily rotated for these chronic meds, and there's no uniform chronic medication formulary. People don't know that personal stockpiling is important or are unaware or confused by the directions. Is it a 3-day supply that I'm supposed to have? Is it an 8-day supply? Is it a 30-day supply? How do I get it? How do I figure out the system? Patients don't know what meds or dosages they take. They don't bring their medications or their bottles with them when they evacuate. Physician offices are closed, and you can't get that information from the physician offices. The pharmacies are closed or damaged or evacuated, so there's no access to those records, and not everyone is connected to electronic medical records. There are workarounds to the systems, but patients and providers aren't always aware of them, or frankly, they don't know how to manipulate them, and preparedness for this is not a priority. Look at this guy. He's got like 17 things that he's got to bring with him in his personal stockpile, and chronic med is not anywhere on there. Rx Response is run by the Pharmaceutical Research and Manufacturers of America, and it provides a pharmacy status reporting tool. ASPR has the Emergency Prescription Assistance Program, which is subject to Stafford Act regs, and it is restricted. There's major retail response assets like mobile pharmacy trucks and stockpiles. There's insurance vacation overrides and education campaigns like Ready.gov. But you need a simple, easy to understand campaign for our patients. Refill earlier, stockpile, and take it with you when you evacuate. We need to educate the public, but also prescribers and other healthcare practitioners to help prepare patients and make them understand that this is a priority. We need to educate pharmacists to counsel patients when they receive their prescriptions. We should never meet for the first time during a response. How often do we say that? We need to meet with pharmacies ahead to discuss their business continuity plans, their expected response actions, and their response capabilities so that your plans are based on the right assumptions of their capabilities. This is a preparedness and chronic disease problem, which can only be solved with a preparedness and chronic disease combined solution, with combined plans, combined programs, and combined funding. Both preparedness and chronic disease can develop best practices and disseminate them with training programs and toolkits. The toolkit should be for health department planners, program staff, healthcare practitioners, prescribers, and pharmacists. Each of those audiences has a different role, so they need a different toolkit. There's data on chronic conditions available. These numbers should be reviewed, and we've heard hazard vulnerability assessment a couple times here today, but they should be included in the HVAs, and they will help you guide program decisions on special populations planning. And this information could help you to develop a localized chronic medication formulary for a cache if your jurisdiction chooses to do that. The CDC Office of Public Health Preparedness and Response and the Division of Diabetes Translation and other chronic disease programs at the CDC convened an expert panel to identify these issues and solutions and to attempt to address the problem. So if you would like to get any information from myself or Dr. Allweiss in the back, she's raising her hand back there, we'd be more than happy to help you and get you connected with our white paper, which we're developing now. Thank you.